Welcome friends to another lecture on the acid-base homeostasis series. As said before, I am going to start each of my lecture with a quotation for the date, and this is from the great personality. There is no words to describe him. I've had the fortune of meeting him once, and he is awe-inspiring to every word that we think of him. This is one of the statements which he made and which I think is very useful for us to understand. The past is a waste paper. The present is a newspaper. The future is a question paper. So read and write carefully, otherwise life will become a tissue paper. Right. So carrying on with the series of the acid-base homeostasis disorders, we discussed about the classification of acid-base disorders, we discussed about the buffer systems, we discussed about the renal and respiratory compensations, we discussed the differences between arterial and venous blood gas analysis, we discussed the differences between direct and indirect ion sensitive electrodes, we discussed about how a sample should be corrected properly, what are the pre-analytical errors that occur during sample collection, and how does it affect patient management. In the present lecture, we are going to understand how to interpret an ABG report and how to make a clinical diagnosis. The questions that we should ask ourselves, rather than understanding patterns and algorithms, we should understand a pattern based on logical activity and come to a working and a logical conclusion. So when we look in an ABG report, there are three parameters we look for: the pH, the PCO2 and the bicarbonate ion concentration. Now in this, which of the parameter is a calculated parameter? This is something, if you don't know the answer, go to my previous videos, you will get the answer in that. But while ordering a ABG or a VBG, we look at these three parameters: the blood pH, the normal values are here, we look at the PCO2 concentration, and we look at the bicarbonate levels. Now this is a classical ABG report. The pH is there, the PCO2 is there, and the bicarbonate is there. You see the pH is low, so this is acidosis. Now the question is, what is causing this acidosis? What we observe over here is that the PCO2 is lower than the normal range. Can a low PCO2 cause acidosis? Now we know that PCO2, CO2 plus H2O gives H2CO3. So CO2 and carbonic acid is synonymous. Can a decrease of acids cause acidosis? And the answer to that is no. So this is not respiratory acidosis. Can a decrease in bicarbonate levels cause acidosis? Yes, bicarbonates are alkalis. Bicarbonates are supposed to maintain the blood's pH in the alkaline range. So if you lose alkalis, obviously you're going towards acidosis. So a decrease in bicarbonates can cause acidosis. So when we say a low HCO3 causing acidosis with a low HCO3, the diagnosis is that this is metabolic acidosis. So the next question is, why is the carbon dioxide levels low? Now when you have acidosis, then the blood pH changes, the CSF pH may also change. There is hyperventilation with an event of washing out all the carbon dioxide, so that you're losing some acids to compensate for this metabolic acidosis. So the PCO2 levels being low indicates a respiratory compensation. So here we have a low pH, a low bicarbonate. So the primary event is a low bicarbonate, which is metabolic acidosis. The low CO2, PCO2 indicates that there is respiratory compensation. Now let's go to another case to understand the same concept. Here we have a pH of 7.21, we have a PCO2 of 55, and we have a bicarbonate of 33. So the pH is low, so that is acidosis. The PCO2 is higher than normal. Can a high PCO2 cause acidosis? And the answer to that is yes, because we are retaining carbonic acid and carbonic acid is an acid which will lead to the production of acidosis. So yes, a high CO2 can cause acidosis. So this is respiratory acidosis. Now the bicarbonate levels are low. Why is the bicarbonate levels low? Because there is acidosis, the body is trying to retain all the alkalis it can possibly retain to neutralize the excess of acids. So the tubular system for reclaiming bicarbonates increases and the bicarbonate levels increase. So this indicates that there was an element of renal compensation. So we have a case where there's acidosis, the PCO2 is high, indicating that this is a respiratory acidosis. The bicarbonate levels are high, indicating that this is a respiratory acidosis with evidence of metabolic compensation. On its own, a high bicarbonate level will not cause acidosis, so this is definitely not the primary event. So while understanding and interpreting an ABG, we follow the basic rules. See the pH. If the pH is low, we are dealing with acidosis. If the pH is high, we are dealing with alkalosis. Pretty logical. Now, if the pH is in metabolic acidosis, what is the primary cause? The primary cause is some acids are being produced. The body's immediate response will be to use the buffers, bicarbonate buffer system to neutralize the acids. So the primary event you will see in metabolic acidosis is a low bicarbonate. Over a period of time, the acidosis will stimulate the respiratory centers for hyperventilating, and when there is a renal compensation, you will find that the PCO2 levels are low. In respiratory acidosis, the primary event is that the body is not expelling out all the carbon dioxide, so the PCO2 levels are increasing. In respiratory acidosis, the primary event is a gain in PCO2. Because the PCO2 is increased, the kidney will try to reclaim all the bicarbonates to neutralize the acid. So as a compensatory mechanism, you will find that the bicarbonates are high. Metabolic alkalosis. What would be the primary event? The primary event in a metabolic alkalosis will be that the bicarbonate levels are high. A high bicarbonate level will produce alkalosis. This is example of metabolic alkalosis. In order to offshoot this alkalosis, the body will try to retain all the carbon dioxide, and so you will have an increase in the PCO2 as a compensatory mechanism. In respiratory alkalosis, the primary event is that the patient is hyperventilating and losing all the carbon dioxide. So you will find that the primary event is a decrease in the PCO2. Now, because there is loss of acids and there is alkalosis, the kidney, to compensate for this, will tend to excrete all the bicarbonates. So you will find the bicarbonate levels low, and this indicates a renal compensation. So whenever you look at an ABG report, first look for the pH. Come to a conclusion that is it acidosis or is it alkalosis. Then read the PCO2 and the bicarbonate levels. There you will be able to understand what is the primary precipitating event, and you will also get an insight whether a compensatory mechanism had occurred or not. Please do not go by pattern identification. Low pH, low PCO2, low bicarbonate, this is metabolic acidosis. Low pH, high PCO2, high bicarbonate is respiratory acidosis. Don't go by pattern recognition. You are liable to make mistakes, because the pattern which you see in a respiratory acidosis and the pattern which you see in a metabolic alkalosis is similar. The pattern which you see in metabolic acidosis and respiratory alkalosis is similar. So if you go by pattern recognition, you're always going to end up in mistakes. If you go in a very logical way as to first finding out what is the pH, classifying it as majorly as acidosis or alkalosis, then reading the other parameters and deciding what is the primary event, and then checking up whether there's evidence of compensation or not, you will always be right in interpreting an ABG report. And interpreting an ABG report is very essential because this is the starting point for patient management. What I've discussed in this lecture is a broad overview discussing clear zones of between what is black and white. But in true situations, you do not get black and white, you get gray zones. That is, a patient with metabolic acidosis with an element of respiratory acidosis, a person with metabolic acidosis with an element of respiratory alkalosis, and the combinations can be multiple. So understanding the ABG report becomes a little bit more difficult. So in this video, I discussed what is black and white. This is the formation for understanding the next lecture. The next lecture will be taken by my friend Dr. Anand Shankar. Dr. Anand Shankar, as I told you, is an anesthesiologist and a critical care specialist. So he will explain to us the various shades of gray and how the ABG report should be read to understand these gray shades. Then he will also go on to discuss how the ABG report guides his patient management and how patients of acidosis and alkalosis are managed. This is going to be in the next series of lectures. In the meantime, you could contact me at my email ID arunharit@gmail.com or QS in Biochemistry. Constructive criticisms are always welcome. Thank you.